So good morning, one and all. I'll be talking on glued IOL. This is my financial disclosure. I work as a consultant for biotech healthcare. So there are 4 situations where you will need to do any of these techniques. But I strongly feel all the techniques had a parsplanal vitrectomy, and glued IOLs or secondary IOLs are realm of vitreoretinal surgeons. So simply because in the era of refractive surgeries, you need to have a refractive like outcome at the end of the surgery. And I will just reiterate a few points on how we can achieve it. So when you have a situation where the patient has a subluxed lens or dislocated lens, or when the patient can, this is a IOL which cannot be repositioned, and you can see the tilt also, which is evident on this antersegment OCT, or when everything looks innocuous aphakia, but there is a massive vitreous prolapse in the AC causing decompensation of the cornea. Those are the things which we need to really give attention to and do. IOL is just a part of the surgery. You have to take care of all these things, and which is can be only be effectively managed if you have a good vitrectomy system in your hand. And this is iris clip IOL, where you can see not everyone is as good surgeon as Vaibhav. So average surgeons like me can struggle with techniques like iris clip IOL. And patient, even though patient can have 6/6, but because of the Stiles-Crawford effect, he might be complaining of visual problems. And of course, on OCT only you will be able to see the vitreous prolapse and all the associated astigmatism problem. And astigmatism is one of the grossly neglected problems in the secondary IOLs. So as we all know, Gaber in 2007 gave this landmark paper, and all the other techniques are basically a rehash of the same principle. The goal of the surgery of any surgery should be restoring the anatomy. We should not distort any of the anatomy, because that is very, very important. So this is where this angle anatomy comes into picture. So this looks so innocuous, but if you see the angle, you will see there are multiple things going on there. There is Schlem's canal, there is iris root, there is trabecular meshwork, and this is where you are meddling with, and which will cause long-term problems. So basically, Sharra's technique had 2 main things. One is 1.5 to 2 mm from away from the limbus, which actually is the danger area which we should avoid from, and also to achieve an effective lens position and alignment, which will give you very good refractive outcomes. So this is a case where, sorry. So as you all know, this was a subluxed lens, which I tried initially with the cutter, but it is after parsplanal vitrectomy, it is always better to use a phacophragmatome. Even though it, however soft it may appear, it will reduce the operating time drastically. Once it's done, there can be an associated breaks which can be lasered and finished off on the table itself, rather than doing it post-operatively, which an intersegment surgeon cannot be done. And marking these with the RK marker at 180 degrees apart is extremely important. And once you mark that, you make a measurement of 2 mm, and with the help of this handshake technique, you can exteriorize. But in this case, as I told, the previous speaker mentioned, the risk of lens drop. If it happens also, it's of no issue. We can always refixate by elevating with an extrusion cannula, and by measuring at 2 mm, you can give almost an effective lens position like alignment. and we don't have to change with the biometry as well. And this is the Chariot's tunnel, which will help you to fixate without needing any additional equipment. And once you externalize the haptic and nudge it into the Chariot's tunnel, you can close it with the glue. So this is another case where there was IOL drop where we cut the lens and not able to. So we used a lens cutter to without enlarging the incision, we removed it and then injected a new IOL, and the same technique can be used. So this is a case of a multifocal IOL where I fixed a multifocal IOL. If you follow the principles, you can achieve alignment where you can achieve centration like a normal lens, and also get rid of any post-operative visual problems. This is the patient who had an outcome of 6.6 and 6. I have done multifocal SFILs also, and this is a very good technique, and we can have refractive like surgery like outcomes. And this is the Chariot's tunnel which I'm showing on OCT, where how the haptic is being tucked into this thing. This is the kind of IOL centration we can achieve. And in these days, medical legal issues are definitely a problem if you have suboptimal outcomes. This is one case where a patient had a PCR and a suboptimal outcome. So you should choose the right technique to have a good refractive like surgery like outcomes. And this technique, any of these techniques can be a refractive doppelganger, and definitely glued IOL scores above all these techniques. Thank you.